key researcher behind the clinical trial for the drug, is our guest tonight, Dr. Andre Khalil. Doc, thank you for being on Primetime.
Thank you very much, Chris. Appreciate it.
No, hey, I appreciate you taking the opportunity. You're the best guest for this. So give us your take. What is your level of enthusiasm about this drug's efficacy, and what do you believe its efficacy to be?
So this is a very important question, Chris. I'm one of the principal investigators for the NIH trial. This trial, it was run mostly in the United States with about 50 different sites here, about 20 sites outside the United States, South Korea, Singapore, Japan, Denmark, Germany, and so in Spain. So this is a very large trial. It's sponsored by the NIH. Dr. John Beigel, it was the lead on the process at NIH with a large group of very experienced investigators. And here, University of Nebraska, I'm the principal investigator. And we start actually this trial right on February 21st. We enrolled the very first patient of this very important trial. In February was one of the patients that came on the cruise, on the Diamond Princess cruise. This trial actually, the very interesting aspects of this trial is that a very strict methodologically. So this is it is as strict as it can be in terms of a scientific methodology. We're talking about a.
All right, so it's legit. It's legit. The study qualified. It wasn't too small a sample. It wasn't double blind. It was peer reviewed. It checks all the boxes. That's good to know. So we should listen to it.
Chris, yeah, absolutely. Chris, importantly, it's not peer reviewed yet. So, but the preliminary results the preliminary results are so important that we decide that this has to be out to the public, that everyone has to know, because the results are so significant from the statistical perspective that we cannot just hold and wait for a whole process to go through and see what's going to happen, because we believe that.
Well, let's talk about why that is, Doc.
Yeah,
let's talk about that. Now, let's just be very clear. You're a researcher, you're a highly skilled academic and clinician. You're not a politician. I'm not asking you to sell the drug to people, but Wall Street went crazy, and releasing preliminary data is unusual. You are saying the same thing Dr. Fauci said, which is, yeah, but this data matters so much that we needed to get out. Why does it matter so much? It's not like this is a pill that you can take where you'll never get this. It's not equivalent to a vaccine. Why did you think that the research was so important it needed to come out?
Great question, Chris. So here's the deal. This is really, really important. This is what I've done for 20 years. I'm very much, as you said, I'm a clinician. I'm at the bedside taking care of my patients. This is my first thing I do in life. And together with my clinical care, I've done clinical research for all these years. So this is really what I do for life. That's my 24/7 activity. When we participate in a trial that strict, that robust in terms of double-blind and placebo-controlled, with the sponsoring from the NIH, we are talking about probably at this point in the middle of this pandemic. There is no trial that has been done with such a strict methodology. So this is that's very important because, as you know, there's a lot of pseudoscience going out there, a lot of fake science out there. This is absolutely true science, and that's why I'm participating in this trial, because I believe that this trial really could bring some important findings. So that's the first thing.
All right. So none of the chloroquine stink is on this study. This was done in a different way, so you have more confidence in it. But why are the preliminary findings so potent? What is the eureka moment here that people have to know right now?
So there's two things that are very important for me, and I'm seeing that as not only as a researcher, but as a clinician, as somebody that takes care of patients every day. So the two findings that we know today that Dr. Fauci mentioned was, one is that the time to recovery is reduced by 4 days. This is not a small deal. This is a big deal because it's 4 days out of from 15 to 14 days, about a third of the time that the patients are going to require oxygen, are going to require respiratory support, they're going to require to be in a hospital. You reduce by a third. So why this is important? Because if you ask me, if I would stay 2 weeks in a hospital and 2 weeks minus 4 days, there is nobody that would tell that they would prefer to stay for more days, because every day that you stay in a hospital, you increase the chance of complication, increase the risk of complications, risk of death. So that's from the patient perspective. This is definitely something very important because you're gonna really have a third reduction on your time to recovery. The second thing that is as important as well is that there was a trend, even though not statistically significant because of the trial was not powered for mortality, but there was a trend for improving mortality from 11.6 to 8% with remdesivir. So if you put together
people died, 3% reduction in death.
Exactly. If you put together almost 4% reduction in death with 4 days reduction on the need for hospital and respiratory support, this is not something to take lightly, especially when it comes from a trial that is that robust. Now, this is not a cure, as I said in the beginning. This is not a cure.
Right.
There is almost
let's talk about
anything
that.
Let's talk about that. If you brought the mortality down to zero, and if you had absolutely 100% cure rate, this is not a cure. This is a treatment, and that's why the trial.
I totally get it.
Continue to look for other therapies as well. This is the beginning of the process.
So let's talk context here. Tamiflu, which people are familiar with, you get the flu, you get the pill of Tamiflu. I know this isn't a pill. This is an IV treatment that has to be done in the hospital at this point. But that's not a cure either. Right? It reduces the length of the flu. That's the same dynamic we're talking about here. But in terms of whom it is great information for, not me, somebody who had a nasty case but stayed home, or somebody who gets a case and doesn't have to go in the hospital, or somebody who goes in the hospital but doesn't have an extreme case. This is a drug that, at least as tested, was about extreme cases in the hospital where this was an IV treatment. So we're not talking about something that is a pill that we can pop and it'll make what you deal with at home shorter in duration. So this is a very limited population we're talking about with the drug. Is that a fair point?
It's a very fair point, Chris, and I'm glad that you brought this up. This is a very, very, very important point. This drug is only to be given for people with moderate to severe COVID disease. These are patients that are actually not only have the infection, but they have the infection already spread to the lungs, causing pneumonia. They require to be hospitalized. They require to receive oxygen or mechanical ventilation. So these are definitely patients that are in the more severe spectrum of the disease, and that was the goal of the clinical trial. This is not a medication that should be given to anyone that don't meet what we met in the inclusion criteria of the trial, meaning that you have to have pneumonia from the coronavirus, you have to be hospitalized, requiring oxygen or requiring more respiratory support. This is a very important point, Chris. I'm glad that you brought that up. And it is an intravenous medication that requires an intravenous catheter to be administered as well.
Let me get one public policy point from you before I run out of time with you. And I want to just say in advance, Dr. Khalil, I know how busy you are with processing this study right now and your other clinical work. I really appreciate you taking the time because the country's hearing about this now. They need to hear it straight right now. And they're not going to do better as a source than you. You've got no agenda other than the science of this. So people will hear about this. Remdesivir. This is it. This is the cure. We can reopen now. We're going to be okay. Stop with all this isolation, all the mask craziness. We have something that'll keep us from dying. Let's reopen. Let's be more ambitious. What is your caution?
Well, I can tell you with 100% certainty, Remdesivir should not change even with the data we have today, with the positive data that we can shorten the time of disease, we can potentially save lives. Remdesivir will not do anything in terms of public health. And Remdesivir is going to benefit people with moderate to severe disease that are right in a hospital. So just having the Remdesivir available, let's say if the FDA approves the Remdesivir available, it's great. It's going to be great to benefit patients that are sick, very sick from COVID in a hospital. But when it comes to public health, Remdesivir is going to have absolutely no impact because Remdesivir is not a drug to be used to prevent an infection. It's not a drug to be used in somebody with a mild infection at home that will improve, will cure without any medications. Remdesivir is for a very specific, it's a small proportion of patients that get really sick, that have a high risk of death, and this is the patient population who benefit from Remdesivir. So Remdesivir should not have any significant impact in terms of public health policy, in terms of opening or closing. This is a whole different subject that will not be influenced by the availability of remdesivir. This is a very important thing to understand, that prevention and treatment are two very different things, and they should not be confused at all.
And I'll tell you the hopeful thing, we finally have a tool in the box. Remdesivir is the first thing that we know with science behind it you can give to someone who's in extremis, who's very sick, and it will help them. That's the first thing we've been able to say that about with certainty. And a big reason we can say it is because of you, Dr. Khalil, and your team. Thank you for killing yourself to do this research and getting it right and getting it done so soon. Thank you, sir. God bless you and your family. Stay healthy.
Thank you. It's a team effort. Lots of people working together, NIH, investigators all over the world. It's a huge team effort at University of Nebraska. It's really an effort of so many people, and I cannot thank everyone here, but it's just the beginning. We're going to find more treatments and more things that hopefully are going to improve the lives of all these patients being affected by the disease. Thanks so much for the opportunity, Chris.
Doctor, thank you for taking it. Made a big difference. I can't get a better source from my audience than you. Be well. Appreciate it. So just quick sum up. We finally have a tool in the box. We're losing way too many people. You know the ratio of people who go on ventilators to get off? It's not good. In fact, it's shockingly bad.